Introduce our speaker for today, Dr. Jeffrey Healey. He is going to talk on hot topics of atrial fibrillation screening and subclinical atrial fibrillation. So Dr. Healey is currently the director of the Division of Cardiology at McMaster University and Hamilton Health Sciences. He's an endo chair for the Salim Yusuf Chair in Cardiovascular Medicine. He is also a full professor of medicine at McMaster University, and he is a chair of the Canadian Stroke Prevention Intervention Network, or CSPIN. In addition, he's also a scientist at the Population Health Research Institute. So I have the privilege of having known Dr. Healey for now 20 years. We were both colleagues, and so I have great insights into his beautiful mind. I would call it a beautiful mind. And to be precise, he's always excelled in whatever he has done, and his accomplishments are too many to list here. Suffice to say that he has got multiple peer-reviewed grants from Canadian Institute of Health Research, Heart and Stroke Foundation, and has published multiple articles in NEJM, Lancet, and other high-impact journals. You can always look them up. They've all changed practice, and I was privileged to work with him on some of these trials. So he is also an excellent clinician and does a lot of procedures, unlike a lot of the high-end researchers who don't do that. And I know that Jeff has done a huge number of devices and cardiac ablations. His passion is VT ablation. Not many people know that. And other than that, he's father to two lovely daughters, one of who's going to McGill, and I had the pleasure of seeing both of them from when they were born. And with that introduction, I'll let Jeff Healey take over and thrill us with all the stuff he has to tell us today. Thanks.
Thanks, Girish. That's a real kind of family-style welcome, and I appreciate coming to Ottawa. I grew up here. This is my hometown. My family still lives in Stittsville, and it's great to see so many familiar faces, most of which haven't changed much over the years, unlike the building here, which has become big and beautiful. I'm going to talk about atrial fibrillation, and it's a bit of a split talk. I'm going to start with subclinical atrial fibrillation, which is what Girish was talking about, and then move into some additional work we're now doing in stroke prevention. So with that in mind, we'll work on the delay here. There we go. So the overview of what I hope to cover is going to be subclinical atrial fibrillation, and this is asymptomatic, short-lasting AFib, so minutes to hours worth of atrial fibrillation detected with long-term continuous monitoring. Okay, so that's what we mean when we mean that term. It's stuff that would go under the radar, would never appear in the Framingham study as a patient with atrial fibrillation, but is out there, and I'll just show you how much of it is really out there. We're going to talk about the contentious issue of atrial fibrillation screening. Is this something society should be doing? It's certainly an agenda that's being driven by patient groups as well as patient-facing corporate interest as well. Apple Heart, everyone's heard of that. We're going to talk about other outcomes in atrial fibrillation because there has been some change over the years in terms of what it is that is the greatest risk to those patients with atrial fibrillation. And I'm going to talk at the end about our LEOS program of atrial appendage management for stroke prevention. So with that, I want to also communicate a few key concepts. So I'm going to, pull the typical, I'll tell you what we're going to talk about, what I'm going to show, we're going to show it, and then we're going to review it at the end. So I'm going to make a few points. Subclinical atrial fibrillation is very common. If you look at older individuals in North America, especially those with cardiovascular risk factors, it's very common, and we'll show you precisely how common it is. Second point is I want to convince you that there's a relationship between the amount of atrial fibrillation one has and stroke risk, that this correlation between burden and stroke risk is real, and we have to understand what that actually means for how we manage patients. I think atrial fibrillation in some cases can be a risk marker as well as a direct cause of atrial fibrillation, and some data to show that. And I'll also introduce the idea of residual risk, that despite our best efforts with really great oral anticoagulants, that many patients have remaining risk of stroke, some of it potentially modifiable, some of it not, and this is an area we're going to study further. And as I mentioned before, stroke is a very important outcome for patients with atrial fibrillation. but there are other outcomes now that we should be focusing on as well to improve overall performance. So, subclinical atrial fibrillation. When I left Ottawa back in, what was it, Marty, 1999, 2000, something like that. I remember there was a big party for the millennium, so it must have been around then. I came and I said, okay, I want to do clinical research. This is great. And they said, so what are you interested in? I said, I'm interested in atrial fibrillation. I'm interested in devices. And Stuart Connolly told me, he said, that's not a very good way to start. He said, you got to focus, pick one. And I said, well, they're both kind of interesting. And so I ended up agreeing that I would do atrial fibrillation detected by devices. So I covered off both bases. And that's how I started down this rabbit hole. So this is the type of electrogram that you see here in the top left, atrial arrhythmia. It's probably atrial fibrillation. It's hard to tell sometimes between an atrial fib and an atrial flutter when you're looking at a single point in the right atrial appendage. But subclinical meant short-lasting, minutes to hours over the course of many years of monitoring, and asymptomatic in nature. And when we started, you know, we had all these devices, and like many features on our pacemakers and ICDs, they gave us data that we A, didn't know what to do with, and B, didn't particularly want to do anything with it. And I would argue that when I was a fellow 25 years ago, we didn't largely do much about these because, of course, the only drug at our disposal was warfarin. And we could usually talk ourselves out of, hey, it's, you know, a couple hours of AFib over the course of the year. Do they really need to be on warfarin every day? And, you know, those equations have changed a lot over the years. The other thing that made us pause, and it was probably smart, and I would contend that, you know, as Girish said, I think to do good clinical research, you have to have some grounding in good clinical medicine. Otherwise, you ask questions that are irrelevant and you get perspectives that can be a little unfocused. And I think what busy clinicians, Marty being one of my mentors, realized is that when you look systematically at patients in a pacemaker clinic, this sort of stuff is very, very common. These are patients in ASSERT, our first big trial in this area. These are patients over 65, history of hypertension, no prior AFib, flutter, or tachycardia. And if you follow them forward with a dual chamber pacemaker, by about 4 years, half of them will have experienced an episode of subclinical AF more than 6 minutes. So 1 in 2. So very, very common if you look hard enough. And if you follow thousands of patients with pacemakers, of course, you see this every single day of practice. So we said, okay, that's a lot of atrial fibrillation, but, you know, people have described tachybrady syndrome for 100 years. You know, maybe there's something unique about pacemaker patients. Maybe this is just a high number because they have sick sinus syndrome, a scarred up atria, and this is why it's so high. So we did another study called ASSERT-2, where we took similar patients who had risk factors, were over 65, but they didn't have a pacing or an ICD indication. And we implanted loop recorders in them and said, okay, how much atrial fibrillation would you expect to find there? And lo and behold, after 18 months, about 35% of people had one episode greater than 5 minutes in this case. So very, very common, longer durations are shown here. And so this is a function of age. Yes, you know, maybe there's some difference for pacemakers, but at the end of the day, this is very common in older people with typical cardiovascular risk factors. So then the question becomes, is this really a disease state, having 3 minutes or 5 minutes of atrial fibrillation, or is this like gray hair and wrinkles? Is this an inevitable feature of age that most people, or many people, although I was amazed that Marino doesn't seem to have any gray hair. So, and he was my program director, so good on him. So very common pacing, non-pacing populations. Now, in the pacemaker study, we did show that if you had episodes lasting over 6 minutes, that there was an increased risk of stroke. It was a 2.5 times increased risk of stroke, which was statistically significant. Now, that's important. It means something, but it's also different than we expected. In fact, in some ways, we got rather lucky with the p-value in that study because we had assumed that the stroke risk was going to be closer to 3% per year. We got 1.7, and it just managed to go in the net. That's lower than we predicted because we based our predictions off of studies looking at clinical AFib, Framingham, Brian Gage's study, things like this. And the relative risk in those AFib ECG-based studies was about 5-fold, and we got 2.5-fold. So it's increased, yes, but it's at a lower rate. And if you want to compare side by side, the white bars are the CHAD-specific stroke rates in ASSERT, the pacemaker trial, where we're looking at short-lasting episodes. And you can see there, you know, the stepwise increase in their risk. If you then compare them, which is always tricky to compare to outside studies against a clinical AF study like Brian Gage's in orange, you can see that for each level of CHADS, the risk is quite substantially lower than with atrial fibrillation, although higher than the blue characters here, which are patients without atrial fibrillation at all. So whether you want to call this AF light, I think we steered away from that because we didn't want to get the message out that you shouldn't worry about this for stroke. But I think when you're talking about screening, when you're talking about risk-benefit ratios, it's important to know that the absolute risk of stroke here is lower than what we're used to in clinical care. So that's a pretty crude analysis, right? Comparison between studies, looking at a little bit versus a lot, kind of crudely. So we then did a very sophisticated analysis where we took all 2,580 patients, and every time they had an episode of AFib on their pacemaker, we classified all patients instantaneously and said, okay, what's the longest episode you had? And we binned people into no AFib, greater than 6 minutes, greater than 6 hours, greater than 24 hours. And you could move up, but you could never move down. So if I came into the study with no AFib, if I had a 6-minute episode, and that was my longest episode for the next 6 months, then I was in the 6-minute group for the next 6 months. And then if I got a 24-hour episode, then for the remainder of the study, I moved and I became in the 24-hour group. And this is what we show here in this slide. So the punchline of this slide is it appears that most of the risk in pacemaker patients with subclinical AF is contained within patients who have episodes lasting more than a day. Okay, so you see the multicolored lines at the bottom, those individuals have no AFib, 6 minutes, 6 hours. Their risk is pretty low. It's about 1% a year. When you get up into the gold line, those are greater than 24-hour episodes. Now the risk is about 5% per year. And that's what we would have expected based on clinical AFib. So for us, that is one line in the sand we can draw with some certainty, probably the only line in the sand we can draw with some certainty today, that if you have more than 24 continuous hours on a pacemaker, that is probably equivalent to having an ECG showing atrial fibrillation. It's high burden and the stroke risk is measurably higher. So that's where we were with the observational studies. The next big question is, what do you do with that in a non-pacemaker patient who you do a 2-week Holter, a 3-day Holter, a 1-day Holter, whatever, a loop recorder for 6 months. And, the issue here is there's a statistical probability. The more you monitor, the more you have to find for it to be significant, right? So if I draw the analogy of this, my parents are big golfers. Marty's a big golfer. I'm not sure that's relevant, but it's interesting. But they owned a place in Palm Springs for 25 years. I went to visit them the first time when they bought the place, and it was pouring rain. I said, wow, this Palm Springs, it's quite the rainy place, right? And of course, for those who know it, Palm Springs is a desert. You can get dates there and go out and hike in the woods, and it gets pretty cold at night. The point is, if you look once and you see something, if I do 12 seconds of a 12-lead ECG and I see AFib, the likelihood is that patient's in atrial fibrillation most or all the time. It might just be they just went into AFib that second. I've seen it, but it's more likely that they're in it all or most of the time. So if I take one look at Palm Springs and it's rainy, the assumption might be it's a rainy place, but in some cases that's not true. The more you monitor, the more AFib you have to find, so it's really a burden consideration. So my colleague, Bill McIntyre, took those ASSERT data, which have been tortured to death over the last 2 decades, or 1 decade rather, and we sampled random 14-day windows within them and said, okay, we're going to just randomly pull out 14 days worth of data. And we're going to look and see what duration of AFib correlates with the 24 hours over the 2.5 years of the study. So what gives us that same risk? And without showing all the data tables, and this is a very data heavy analysis, it turns out that if on a 2-week Holter, if you find 6 minutes of AFib, that gives you the same relative risk and absolute risk as 24 hours on a pacemaker. It's modeled, it's not directly measured, but it does kind of hang with other pieces of data in the literature that 6 minutes on a Holter of 2 weeks in duration. Obviously, if you do a 24-hour Holter, it's a shorter number, and that's just the science. Then, of course, there's the context. If it's a post-stroke 24-hour Holter, neurologists are pretty keen on 30 seconds, and is that the right number? I don't know if it's the right number, but it's gotten a lot of traction, and it's hard to deviate from that. And I certainly don't have data to say it's a wrong number. So how do we resolve this further? I think, clinical practice is always going to supply 90% of your answers, clinical experience, clinical acumen, right? The clinical trials, as I've come to know them, they're like when you go sailing and you have those navigational buoys out there that say, okay, don't go on the right side of this red one or you're going to be on a shoal, that sort of thing. Clinical trials give us very broad guidance, but they don't really micromanage things very well. And so with trials, we're really looking to provide broad guidance. So this is Arcadia, our big pacemaker anticoagulation trial. These are patients with subclinical AF on a pacemaker or ICD, lasting between 6 minutes and 24 hours, and they're randomized to be anticoagulated or not. We enrolled just over 4,000 patients. They've been followed now. I think the average follow-up is over 5 years. And this time next year at AHA, we hope to present these results. So they're in follow-up. We'll close out the study over the summer and have some results. So there is a stratification here based on the longest episode at baseline. So the median duration of SCAF at baseline was around 3.5, 4 hours. And so we'll look at the outcomes on the kind of the high burden group and the low burden group to see if there's any difference. So show of hands maybe. So who thinks treating these patients with an anticoagulant is going to prevent stroke? Who thinks that's a done deal? Trial in Europe, our friends in Germany, Paulus Kirchhoff, called NOAA-AF. This is a slightly smaller trial, 2,800 patients. We're looking here at stroke and embolism as our primary outcome. They're looking at a big composite, including things like cardiovascular death. So a little mess here, as well as TIA, which is always a messy outcome. That's the NOAA-AF design. So it's against placebo, edoxaban. That trial actually will probably present at ACC. So they got out in front of us because they were stopped by their safety board for futility. So futility was signaled to harm. So not sure what that means. Again, I think there's many different things that could mean, and no data have been presented. But I think it's going to be interesting. And Paulus and I have already inked a deal to do patient-level meta-analysis of the two studies. So we'll be able to really try to drill down on what thresholds, if there is a benefit, where does the benefit start? Is it a burden of, 1%, 2%, 5%, 6 hours, that sort of thing. So, so hopefully from here to the next 24 months, we'll be able to supply a lot of answers. And then this will spill over into the regular practice of Holters and non-invasive monitoring. Just quickly, I think I have to speed up a little bit, but neurology, as I said, is a special case, and people are very eager to deliver therapy to prevent stroke. Obviously, stroke is devastating. Cryptogenic stroke patients, long felt that a lot of these strokes were because of silent atrial fibrillation. These are the Crystal AF data where patients got standard care of a Holter after their stroke. About 3% were found to have AFib. The intervention group got an implanted monitor, and about 30% had atrial fibrillation. So unclear if it was causative, right? So you see those curves. A lot of the atrial fibrillation is detected like more than a year after the stroke. So did that cause the stroke? Is that a risk marker? That's hard to tell, right? If it happens a year later. But suffice it to say, about a third of those patients had atrial fibrillation more than 30 seconds on the loop. So Bob Hart's big idea here is, well, if we can really define what a cryptogenic stroke is, or an embolic stroke of undetermined source, why don't we just treat everybody? We have drugs that work. They reduce stroke by 2/3. They're safe, easy to take, and have similar rates of bleeding to aspirin. So why don't we just treat everybody with cryptogenic stroke with an anticoagulant and see what happens? So that was done. It was done a couple of times. Bob's studies here. This is Navigate-ESUS. This is Riva 15 against aspirin. Absolutely no difference in recurrent stroke with roughly a doubling of major bleeding. So the idea of just treating people, this would be elegant. It would, put a crimp in the Holter business, but it would be elegant in that you could deliver therapy for patients before they left the hospital. But unfortunately, it didn't work. And so why didn't that work, right? A third of the patients have AFib. If, we know that a third of those patients have atrial fibrillation on a monitor. Should have, could have, maybe it should have worked. Same sort of results we're seeing with the Respect-ESUS. That's a dabigatran trial performed in Germany by Chris Steiner. same sort of result, no benefit. They didn't show an excess of bleeding, however, but no benefit in terms of stroke reduction. So like we usually do, we do postmortems on these trials. Here's a paper that I put out a couple of years ago looking at Navigate. Here we broke it down by left atrial size, so 4.6 centimeter diameter or greater. In that subgroup, there did seem to be a benefit for rivaroxaban compared to aspirin, and that might make sense because people with big atria are more likely to be the ones who have the atrial fibrillation than people with small atria. Similar study from Respect, not looking at atrial size, but looking at age. You know, if you want to pick two really inexpensive and good markers of who has AFib, old people with big left atria. That's where you go. As Marty used to say, if you want to find a needle in a haystack, start looking in the small haystacks. And that's a small haystack. If you're dealing with 85-year-olds, you're looking for atrial fibrillation. You don't have to look very hard. And there, again, there seemed to be about a 37% reduction in stroke with dabigatran here in the elderly group. But these are hypothesis generating, right? These are post hoc analyses of big trials. You can't take this to the bank. There's going to be no guideline change based on this that we empirically anticoagulate patients over 85. But what's happened is this trial that I'm happy to be part of, run by Human Kamel out of Columbia in New York City. This is Arcadia. This is kind of an ESUS plus trial. So ESUS patients who have some marker of a diseased atria. So either a big P wave on their 12-lead ECG, the lowly $3 12-lead ECG is a screening test, very good. Atrial diameter being increased, or a high NT-proBNP. So you have to have ESUS plus one of those things, and you get randomized to aspirin versus apixaban in this case. This trial will complete enrollment in the next 6 to 8 weeks, and we'll have a result in about 12 to 18 months after that. So I think this is probably the last good kick at the ESUS empiric therapy can. So either this is going to work and we're going to stratify our patients with ESUS using echo, ECG, and natriuretic peptides, or we're going to, again, be in a monitoring type strategy where we're talking about wearables, implantables, and consumer-facing monitoring post-stroke. So to shift gears, the issue, we came from the pacemaker world because it was easy to acquire data on atrial fibrillation, good, complete data. This led into the broader question, well, if there's so much of this out there and it's not specific to pacemaker patients, maybe we should be screening the general population to see who has atrial fibrillation. Now, the tall order here is if you screen intently enough, you're going to find atrial fibrillation in a large swath of the general population over 65. And what do you do about it? Is that a worthwhile endeavor? And so, part of the fun in research is actually meeting clever people from around the world. And part of that fun is getting together and working collaboratively on things. So this is a group of individuals doing the major screening trials around the world. We've got another patient level meta-analysis. We've got data that's already being accumulated in Copenhagen, and we're putting together data on the randomized trials. Just by way of backdrop, I talked a little bit about burden of subclinical AFib, these short episodes, more giving you higher stroke risk. The same is actually true, and this is relevant for screening. The same is true of ECG-detected atrial fibrillation. So if you look at the classic ESC, paroxysmal, persistent, permanent definitions, these are data from 2 of our big clinical trials for aspirin-treated patients with atrial fibrillation. And we've adjusted these curves for every possible stroke risk factor, age, CHA2DS2-VASc, et cetera. And what this graph shows is if you're having AFib that's permanent, your stroke risk pound for pound is double that of someone with paroxysmal atrial fibrillation. It's twice as high, with persistent AFib being in the middle. And this is not to say that we don't treat paroxysmal atrial fibrillation. You can clearly see that stroke rate is about 2% per year. So that's a high rate. That's in the treatment zone. But the point here is using relatively insensitive tools to detect atrial fibrillation, such as handhelds. You're largely, again, going to pick up the persistent and permanent atrial fibrillation. And when you're talking about the economics of that, the fact that it's got double the absolute risk makes it, twice as attractive from an economic point of view. That's the point. But again, it makes the whole point that when one goes from, PACs, like if you have 720 PACs a day on your Holter, that's a risk for stroke. If you have a single PAC on your 12 lead, that's a risk for stroke. And that's very, very low burden of atrial arrhythmia. And that gradient, it's not linear, it's kind of lumpy, but that gradient goes all the way up into being atrial fibrillation all the time. And I think you have to keep your mind on that when we're talking about studies. So we did a very simple study here in Canada, Ontario, Alberta. These are community pharmacies, people walking in to get their prescriptions, no history of atrial fibrillation. They submitted themselves to screening for 3 diseases, hypertension, AF, and diabetes. We found about a 2% pickup rate of atrial fibrillation with a single handheld measurement in 65 plus. And when one got into the 85 plus, this was around 8%, had atrial fibrillation on a single time point. Blood pressure, similarly, was poor. About half of these patients having it measured by the book, by the CHEP guidelines, about half of those individuals had blood pressures greater than 140/90. So important when one's talking about screening, if you're screening for the goal of preventing stroke, don't forget about blood pressure because it is a big cause of stroke and we can actually move the needle on blood pressure related stroke. Now, our friends in Scandinavia, Martin Rosenquist, Emma Svenberg, did this series of studies called Stroke Stop. This is as good as epidemiology as you're going to see in contemporary practice. This is crazy good. So these are 75 and 76-year-olds in 2 counties in Sweden. They called up every human being in those 2 counties born in those 2 years. And 60% of those people, 63% of those people said, sure, I'll be in a clinical trial. Unbelievable. So this is as representative a sample as exists today. They gave everyone a handheld device and they trained them on the Swedish method, which was to make a 12-second ECG twice a day for 2 weeks. And, so a couple minutes worth of monitoring. And what they found is 3% of individuals had AFib. And another 2% of people rediscovered their AFib. There were patients that had it on their chart somewhere, but were not receiving an anticoagulant. So about 5% in their terms had actionable atrial fibrillation. And they modeled this. They didn't measure it because that's hard, but they modeled it and said that will cost about €4,000 per quality adjusted life year if we deliver this therapy. And why that works is, these are elderly people. 75, 76. So you're going to find a lot of atrial fibrillation in 75-year-olds. We'll contrast this with some of the consumer studies like the Apple Heart later, where the average age of people screened was like 38 years old, in which case you find nothing. But very good study. But like the Alberta Pharmacy study, shows that you have to be plugged into a healthcare system to make it, because you find atrial fibrillation, great, congratulations. That doesn't prevent stroke. It allows you to determine the cause of stroke when it happens if you don't do anything, but you need to connect it with therapy that works and keep patients on therapy. So where that has landed, globally, patient groups are very hawkish on AF screening, right? It's empowering, and groups like the AF Alliance are very positive on this. Professional organizations like the ESC are very positive and issued guidelines around it. National groups like this, the United States Preventative Services Task Force, are much more sanguine on the issue. These guys look after all screening in the United States. They've given it an incomplete rating. They said, this is great. You find a lot of atrial fibrillation. Come back to us when you have data on stroke prevention and we'll endorse it. And that's where the USPSTF has landed on it. So controversial, right? Because you have, patient forces, doctors, industry pushing all in different directions. But, the USPSTF is actually a fairly wise group of individuals. And, there are not too many screening programs that are endorsed, right? You can probably count them on 1 or 2 hands in terms of, blood pressure, breast cancer, these sorts of things. There's not a whole lot of broad-based screening programs out there. The next thing I wanted to clarify, and this gets into some of the nuance between differences in guidelines. Girish remembers spending a good weekend at the cottage of David Sackett, who was one of the giants in evidence-based medicine, and just a gentleman, really cool guy. Wrote this paper in the Lancet back in the 70s when I was in kindergarten, and showing the difference between screening and what he termed as opportunistic case finding. So most guidelines will endorse case finding, which means the patient's in for their post-stent follow-up or their post-colectomy follow-up, and they're 65 plus and they have risk factors. do something. Measure their pulse, use an automated blood pressure cuff, do an ECG, and they're connected to the medical system for the next 15 minutes, do something in an at-risk population. And that's largely been endorsed rather than screening, which is let's find all the 75-year-olds in Ottawa and get them a Holter for 2 weeks. So this is, the nuance. And when you're reading guidelines, they will call it different things, but what's really being endorsed right now by most people is case finding. And what's uncertain right now is, should we be out, beating the bushes and making sure that everybody gets things screened for atrial fibrillation. So where are we with data? There are a lot of studies, and that's just the list of the studies run by all those happy people on that slide I showed you. This is almost 250,000 people worth of randomized trials. And we've got about 37,000 patients worth of randomized data in-house already. And you can see different countries, different methods, different patient groups. So there'll be a little bit of heterogeneity that'll be interesting to explore. If you look at the pooling, and that's actually the bottom of the forest plot, those are the real numbers. Based on right now, in terms of an outcome of stroke or embolism, there seems to be this soft significance to a 9% prevention in stroke if you screen at-risk people. But it's very early days. You can see here what we call sequential boundaries. We're starting to accrue the data. We've got 37,000 worth. We think we'll need north of 100,000 to barely show that it's meaningful. And so, the Z scores are tracking around 2, which is -2, which is significant, but much more to come over the next 3 to 5 years, just before we nail this down. To highlight 3 of the big ones, stroke stop, we talked about the part 1. The part 2 was they, again, used this epidemiologic approach. They looked at a composite outcome. You can see there, they hit the goalpost with a 4% reduction in their composite, which was borderline significant. Please understand, when you're talking about screening interventions, we never see a 35% reduction in outcome, right? Because you have to screen, you have to detect, you have to treat, it has to work, and you have to keep them on it for benefits. So when you're talking about blood pressure screening or cervical cancer screening or breast cancer screening, if you're getting 5% reduction in your outcome, that's huge. So just to keep a matter of perspective, because we're all used to seeing, 50% reduction in EP trials, right? So it's very much. They looked at it, intention to screen. So they're brutally honest super scientists, that group, and they hit the goalpost. If you only look at people that actually did the screening, there was a 24% reduction in that composite, which was highly significant. So that you can look at that 2 ways, right? As a population intervention, just blasting it out to this age group, maybe it works, maybe it doesn't work. But the question is, if my mother or my father wants to screen themselves, they're like a person who's on treatment or on screening. Is it worthwhile for them? Maybe yes. And so that's a matter of perspective, how you look at that. The loop study, we'll skip over in big detail, but basically it was a randomized trial where a quarter of the patients had an implantable loop recorder placed. I said, wow, that's going to find a lot of short-lasting AFib that doesn't mean anything. Average duration of the AFib found was about 5 to 6 hours. So not trivial. And in their screening group, again, they didn't hit significance on the intention to screen, but for those who actually got the loop recorder, there was about a 25% reduction. In their case, it was on stroke and embolism. So I would have never thought that would show any potential trend for benefit, the loop study, but lo and behold, it was because they were finding very long episodes of atrial fibrillation in a group of patients over 70 with additional risk factors. Now, the mother of all clinical trials is this UK primary care trial called SAFER, Jonathan Manton Company. This is a randomized trial of 126,000 primary care patients being randomized to screening using kind of they weren't settling for the Swedish method. So instead of 2 times a day for 2 weeks, they're doing 4 times a day for 3 weeks. So a little bit more, probably 50% more ECG, and that's where it's going to be. Vital AF is worthwhile to show for one reason. This is a study done in the Boston Harvard system of primary care, and they were doing handheld screening at the time, opportunistic case finding at the time of the visit, and they were looking at the incremental pickup. The bottom line here is the more sophisticated your healthcare system, the better care, quote unquote, that patients get, the more aggressively you're going to need to screen to make a difference. If you go to rural India, like Salim is doing in Pure, and you screen with an iPad with an ECG machine on it, you can pick up a lot of atrial fibrillation that people didn't know about. It turns out if you go to the Harvard primary care system and do that, you find nothing, because everyone's had, 10 years of Holter monitoring by that time anyway. And so a single handheld measurement doesn't add much. The other group that doesn't work very well, this is a cool study to show because of studies. This is the Apple Heart study. What's cool about it is 419,000 patients enrolled themselves, consented themselves, and submitted their data. Like, they didn't need a study team. The problem was, they're largely young, low-risk people, and they didn't find a whole lot of atrial fibrillation, and they found many times things were false positives. So that's where we are with screening. So subclinical atrial fibrillation, asymptomatic atrial fibrillation is very common. Short-lasting episodes are associated with increased stroke risk. We need to define what the treatment thresholds are, and I think that's coming in the next 2 years. Case finding is largely endorsed. Screening, we're waiting for the results of those big trials that I showed, plus the patient-level meta-analysis before making any big conclusions on that. Big impact. When I started medical school, what was the treatment for AFib? Digoxin, quinidine, maybe aspirin, sometimes warfarin. Is that about right, Marty? That's kind of what we did. So we were fairly efficient at harming people. It's amazing how that's changed in 25 years. In our part of the world, stroke is no longer such a big deal in atrial fibrillation. It's a big deal, but it's not what's killing people. Fewer than 5% of deaths in our AF population are attributable to stroke. And that's not my point, really. The point is the big killer of atrial fibrillation we pay relatively little attention to, and that is heart failure. Okay, so about 20 to 40% of all deaths in AF are heart failure related. And, we have to get our heads around how we manage that. People like Radhika Parkash, another graduate of here, looking at risk factor modification trials, looking at MRAs and SGLT2 at that outcome are important, because this is actually what patients with AFib are dying from. Ablation trials even as well, ablation in heart failure patients. So the subclinical AF story is very interesting. My colleague Jorge Wang did this paper off of a CERT. Punchline here is, although subclinical AFib is associated with a 2.5 times increased risk of stroke, it's actually associated with a 4 to 5 times increase in the risk of heart failure, hospitalization, or death. So subclinical AFib is a much better predictor of heart failure than it is of AFib. And so whenever we're called to the device clinic, we've actually modified the way we run the clinic since Girish left. We have a really embedded heart failure program inside our device clinic. When you go down to the clinic and see a fellow with a shock for VT, the most likely cause of death of that patient is heart failure. If you see a patient with a shock for VF, the average survival of that patient is 6 months, and they die from heart failure. If you see a patient with subclinical AFib, we say, okay, should we put them on amio? Should we put them on a NOAC? But the smoking gun there is that patient's going to die of heart failure. And so we have, a heart failure optimization. We up-titrate the usual drugs in the reduced ejection fraction population. And we make it our mission to really find what is the cause of the arrhythmia. Because, we grew up focused on arrhythmias, but the reality is arrhythmia and cardiac function are kind of an intimately intertwined pair. And I don't think you can move the needle very far on heart outcomes in AFib and VT without addressing the heart function issue. Because, patients are not dying of VT, storm, and stroke. It's plain and simple. They're dying of heart failure, and we have to look at that. The other thing is cognition. Associated with atrial fibrillation. If you have atrial fibrillation, your development of cognitive impairment or frank dementia is much increased. If you try to understand why, if you do these type of brain imaging on patients with and without atrial fibrillation, those with are about 10 to 15 times more likely to have those little white dots, which are little parts of your brain that are no more. They are under the radar in terms of clinical stroke. The thinking is if you accrue enough of those things, that's what makes you lose cognitive performance. I can tell you, even in young people with atrial fibrillation, the average MoCA score, and that's like a 30-point scale like the mini-mental, it goes down about 1 to 1.5 points per year on average. And so having atrial fibrillation is an issue. The question is it preventable? You know, can we anticoagulate those patients and prevent cognitive impairment? We have 2 studies looking at this. One is our friend Lena Rivard from Montreal Heart, Brain AF, Ottawa Heart, here's a site, looking at anticoagulating the younger CHA2DS0-1 patients in a long-term study looking at cognitive progression. So these are patients with classical ECG detected atrial fibrillation who are just too low risk in terms of CHA2DS score. So can we prevent cognitive impairment in those patients? That's a 6,000 patient study. And then second, that Artesia pacemaker study that I showed you, we have a 1,000 patient sub-study looking at patients who are older and have the risk factors, but just have subclinical atrial fibrillation. We're doing the exact same neurocognitive test battery as in brain, and looking at what happens in these older patients. And although it's only 1/5 the size of brain AF, when you're dealing with 50-year-olds in brain and 75-year-olds in Artesia, you're going to see a lot more cognitive decline in the 75 and 76-year-olds. So they have almost equivalent statistical power, even though one study is 5 times bigger. So impairment and AFib with anticoagulation this time next year as well. So we'll see. Is that going to work, Marty? That's a key factor. Just a last 5 minutes on our atrial appendage program, just to show you where we're taking this. This has been 20 years. Actually, it started like a year before I came to Hamilton. I worked on it for a bit, and then Rich Whitlock really took ownership and took it to new heights. LEOS 3, you remember reading last year, came out in New England Journal. Simple study, patients coming for heart surgery, valve or cabbage. Half had their appendage taken off, half did not. Double blind, double dummy. Not really double dummy, that's a joke. It was double blind though, or single blind. So no one outside of the OR knew what happened. Here's what the patient profile looked like. So 5,000 patients, they were older with typical risk factors, and about 9% had a history of stroke. Safety was good. We were worried that we're going to have problems with bleeding or problems with heart failure because you're cutting off the appendage where a lot of the natriuretic peptides come from. Turns out neither is of clinical importance. There was a little bit more blood, but like 20 cc's more blood after open heart surgery is falling into the realm of clinically non-important, although borderline significant. Reoperation, 30-day mortality, everything was good. So this proved to be very safe. The cost of it is cheap, right? It's about $5 worth of pledgeted proline, 5 minutes additional to the case. So, and it's a one-shot deal. So in terms of a stroke prevention cost effectiveness, $5 times 1, if you prevent stroke at any degree, this becomes what economists call a dominant strategy. It's both better for patients and saves money. This is what it was done on top of. So about 75 to 80% of those patients were on anticoagulants. So this was largely a study done on top of oral anticoagulation. It's noteworthy that the rates of anticoagulants were the same in the 2 groups. And why that's important, it means we actually did accomplish blinding, right? If the study were unblinded, you might expect far more patients in the control arm to be anticoagulated than the appendage removal arm. The fact that they were pretty much the same suggests that the study did indeed maintain its blind. And it was one of the rare studies that John Mandrola liked about the left atrial appendage, and it was largely because it was blinded. There's the bottom line results. So a substantial reduction in all-cause stroke and systemic embolism with atrial appendage removal. Again, that's largely on top of anticoagulants. And if one does a landmark analysis, taking out the first 30 days where a lot of strokes happen for a variety of reasons, all the stuff that comes up in the bypass circuit or cross clamp, it's a 42% reduction in stroke. So if you think it doesn't add much on top of good anticoagulant therapy, and remember about 2/3 of the anticoagulants here were warfarin, right? Because a lot of valve patients. But 42% reduction in stroke is massive. To do this actually saves the system, tens of thousands of dollars per patient. It actually puts money back in the bank to take off the appendage. So we're trying to replicate this now, and this is my last couple of slides. This is LEOS 4. This is a high-risk medical population. So these are CHA2DS2-VASc score of 4 or more. Permanent or persistent atrial fibrillation, again, keying in on that burden issue. They're on NOAC therapy and they're randomized to catheter-based closure or not. And you say, okay, that's pretty aggressive, right? But for example, if you have a stroke today with atrial fibrillation and you're on a NOAC, whether you're taking it properly or not, your rate of recurrent stroke in the next 12 months is 10%. Okay, so this is a relatively high-risk group. If you look into our clinical trials, in the best possible scenario, these are DOAC-treated patients in clinical trials, the average rate for the permanent and persistent patients is 2% per year stroke on treatment. Okay, so in that higher risk group, there is significant residual risk. That represents somewhere between 50 and 80% of all patients that we anticoagulate. So there is still residual risk to be managed. And so LEOS 4 will be starting up around June of this coming year. So my big conclusions and then question period, which I saved a few minutes. Subclinical atrial fibrillation is very, very common. And you're going to see more and more of it with the consumer facing and with longer duration screening. We'll hopefully have some answers in terms of what are the thresholds for treatment, and those will be coming very shortly. I think I'm optimistic that ECG-based population screening will actually work. The caveat being you have to screen the right patient groups. You can't screen 50-year-olds that are just worried about things. You have to screen older people, and you have to get them plugged into treatment. And if you can't do the latter, then it's just a nice squiggle on a piece of paper. OAC is excellent. It's really moved the needle. It moved stroke down to a minor player of morbidity and mortality in our patients, but there are still patients with residual risk. These are the higher CHA2DS2-VASc patients, the post-stroke patients, and we're exploring kind of a new paradigm, which is combination systemic and mechanical therapy. Why not, right? We've done it in coronary disease for 25 years, right? I mean, would you put a stent in and not prescribe a statin? That would be not cool, right? Or give aspirin or treat blood pressure. And so, you know, we've been a very bullish lot in EP. We think we can cure things with a catheter because WPW is fairly well cured with a catheter. But when we're dealing with chronic age-related diseases like atrial fibrillation, I think we have to do better than that. We have to jump on the same risk factor bandwagon as our coronary colleagues, and we have to look at a broader scope of outcomes, not just arrhythmia, but things like heart failure. And I think that's the last thing I'd like to land on. Heart failure is the big epidemic that we're going to deal with. I think as EP docs, there's been a bit of a paradigm shift over the last 5 or 6 years. We're much more understanding that this is the outcome that harms our patients. Collaborations with heart failure colleagues, better integration of those units, I think is going to be key to move the needle if we actually want to keep seeing our device patients come back every year. So with that, I'll take questions. Thanks.
Thanks, Jeff. Thanks for wonderfully and very precisely, highlighting the unclear aspects of the population, diagnosis, management of atrial fibrillation, and some of the unresolved issues. It's a really enlightening talk for all of us. There are no online questions at present. And I'm going to open this to the floor to ask questions. Just one question before I go to Dr. Lou, who's already got his hands up. One question to you, Jeff, is, probably it's because of time. Your own research has showed that not all strokes are related to an epoch of AF. And, there are other risk factors in such individuals. So how do you tease out the contribution of AF versus non-AF related aspects to developing strokes? And, which will sort of tell us what the limit of treatment of AFib will, how it will prevent for the strokes and heart failure.
Yeah, I think it's an excellent question. I think when we teach in medical school about the causes of stroke, I think that's good. We have to understand how stroke occurs. The reality is those causes are highly overlapping. Okay, I give a story of a colleague's husband that I saw came in with a TIA, and he had a 99% ipsilateral carotid stenosis with a clot hanging off of it. Okay, so that's as smoking gun as one gets. So he has an ENDART, the clot's pulled out, he's doing well. Post-operatively, he goes into AFib for 4 days. Okay, and then he comes back 3 years later and he has a stroke. This is his only actual stroke. And since we had all these MRIs on his brain, we saw that it was a subcortical lacunar stroke that he had. So the point being, this was an 80-year-old guy with typical cardiovascular risk factors. And yes, we can try to pin down cause of stroke, and it's interesting for studies like Crystal AF. The practical matter is you got to look at the patient holistically and say, this is an 80-year-old diabetic with hypertension. Any one of these things can happen. And so a really nice Canadian study was Brian Buck from a stroke neurologist out in Edmonton, published, I think, in JAMA this past year. And they did the Crystal AF study, loop recorder study, but in all-cause stroke. So they didn't just limit it to an ESUS population. They took patients with lacunar stroke or atheroembolic stroke. And why not, right? I mean, if a person has a carotid embolism like my colleague's husband, and you find, they go into AFib for 3 days, are you not going to treat it? You can say, well, that's, they're not having AF-related stroke. Of course you're going to treat it. And so the same logic. The problem is, in current medicine, we're so technical and we're so siloed, and we're really good at dealing with our own little thing. And we say, well, I'm an EP doc. Do I really care that deeply if the patient's on Entresto or not for their HFrEF? Like, do I? And the answer is yes, I do care, because, if you want to have your patient survive, either you got to manage that, and, you're a FRCP cardiologist, you can prescribe the drug if you want, or you get a partnership going with your heart function people and get it done. Because, so I think we learn the mechanism by coning in very closely. We practice efficient kind of Henry Ford style medicine by focusing in very closely. But, to move the needle on outcomes, you got to stand back and see who's sitting in the chair there and what their issues are and what's going to get them. Because if all you're focused on is, are they having palpitations and are they taking their anticoagulant, you will probably miss the boat on your AF patient.
Thanks. Dr. Luke, you had a question.
Oh, Jeff, it's just fantastic, masterfully done as always, and with a focus on the patient, right? It's really actually looking from multiple angles. And so I always remember that you kind of originally challenged the concept that, AFib is actually a rhythmic event primarily that leading to stroke. It may actually reflect the underlying myopathy and those type of concepts. I don't know how you feel at the present time. Of course, our bias, when we're doing research is thinking that, there's a link between even atrial myopathy and ventricular myopathy, and, in terms of link. So the question is that even for these, sort of earlier stage, lower burden atrial fibrillation, our treatment focus has been always on anticoagulation so far. Would it be, in fact, eventually you think down the road, given, for example, a study like Crystal AF, and obviously depending on how it comes out, is that, patients, for example, with lower burden, but if they have elevated NT-proBNP, they actually probably should not just focus on anticoagulation, or maybe not even necessary anticoagulation, but in fact, things that treated underlying myopathy. And, patients, let's say, have other risk factors, let's say hypertension, diabetes, and things like that, so maybe GLP-1 agents, in fact.
Yeah, so good question. So we actually just had a really couple good strategic planning meetings with the heart failure group from Detroit. And we will probably start a large factorial trial looking at MRAs. And it hasn't been determined finally if it's SGLT2 or one of the newer agents, the ones, SGLT1s, that we might use in a factorial design in the AF population, actually in the SCAF population, to look at heart failure outcomes. I mean, Radhika's doing a very good job, and there's as you know, a rehab study based here at Ottawa Heart, where the rehab intervention is being delivered for a multimodal, like they did in Australia with Prash Sanders and their group, looking at weight loss, smoking cessation, alcohol reduction, all those things, and those are important, right? That probably matters. The challenge there is those are really hard studies to do, right? It's a lot easier to execute a 6,000 patient 2-pill factorial trial than it is to get people to come in. But to the credit, actually, the Ottawa group, the rehab group here is doing a pretty, I know from our own patients in the study, they are turning up to visits and they are moving the needle on their risk factors. So I think you can do both, right? I think, but they're both important. So I think, yes. it is important. We're also making some exploration around a SCAF ablation trial in HFrEF. So you have subclinical AFib, you're not even symptomatic, but you have an EF of less than 35, you have an ICD. What's going to kill you? Heart failure. I think both Cabana and then RAFT AF suggest, maybe not overwhelmingly convincing, but strongly suggest that you can probably move the needle on heart failure if you interrupt the atrial fibrillation. And in the early AF theme, maybe we should be getting in when those patients are just starting to have AFib when their atrium's this big, rather than waiting till after their fifth cardioversion when their atrium's this big, and getting in early with some of our new tools like pulse field ablation and very quickly isolating the four veins and seeing if we can move the needle not on stroke, but on heart failure. So those are those. If I do those two trials, those will probably be the last two big trials I do, because all these trials take 10, 12 years, right? So.
Jeff, just a quick question. You come from a center where we always talk about primordial prevention rather than primary prevention. So as I see it, the left atrium, the afterload for the left atrium is a left ventricular end diastolic pressure and, hypertension and other issues. So what is your, what are your thoughts on primordial prevention of AF, which, by addressing those risk factors? I mean, you worked a lot on hypertension and AF.
Yeah, so the pressure thing, just as a little aside, because it's topical, this atrial shunt therapy for heart failure doesn't touch AFib, funny enough, but maybe you wouldn't expect it to.
Too late, yeah, probably.
In terms of primordial prevention, obviously Salim is still kicking around the big polypill trials. That will eventually contain an AF component to it. Yeah, I think if you move the needle on the big risk factors, and those would be, weight, apnea, hypertension, smoking, alcohol, the population attributable risk of those 5 factors is over half, right? So if you can move the needle on those things, the problem is those are largely socially constructed illnesses, right? So to attack those, it's not so much patient doctor in a room, it's society, how we live, how we eat, how we work, how we travel are the big interventions, in a real primordial sense. There's also the variability around the world, right? So tall Northern Europeans probably have the highest rate of atrial fibrillation in the world, right? We did lots of analyses from various studies. In fact, ASSERT was very good because it was unbiased, right? There was no ascertainment problem. And, tall Caucasians are very much, those are 2 big risk factors. And if you go to an African-American population, you go to a Southeast Asian population, AF incidence rates are about half. There are genetically determined components. So it's like every other disease in cardiology. There's a nature and there's a nurture aspect to it. But yeah, I think it's, in general, we don't measure it, but, just good diagnosis and treatment of hypertension probably prevents a lot of atrial fibrillation. We just have never measured it. It reduces stroke. Part of that reduction is probably through atrial fibrillation. Part of it is independent, but, those are studies probably never get done.
Dr. Lentz.
Jeff, fantastic talk. Really excellent. Thank you so much for coming. Can you comment on exercise, athletic AF patients who are, we know that there's some increased risk. Is this a different population? Are they at different risk, and so on?
Yeah. So let me preface it by saying exercise is good, and any activity, perceived healthy or otherwise, done in an obsessive way can probably get you into trouble, right? So obsessive running, you can burn out your knees, let alone atrial fibrillation. I have my own separate little clinic just for, 50 to 70-year-old doctors who run and drink red wine, and they all have atrial fibrillation. It can be devilish to manage, right? Because they all have resting heart rates of 45. And so pick your favorite antiarrhythmic for patients with average daily heart rates of 45 a minute. And we send many of these patients for ablation. I think, the data suggests they do well, at least in the 10 to 12 year period, but then we do see people coming back as they get older, and a number of things are happening. Mechanistically, you've got some hypertrophy there. If they're really, many of these individuals are pretty, when you're topping 1,000 kilometers on the bike a week, that's quite a bit of training. You can bike your way into a frank cardiomyopathy, right? You can bike your way into an ARVC-like cardiomyopathy, and lots of study on the Tour de France riders about how they can bike themselves to VTAC. So hypertrophy, pressure enlargement, vagal tone. We all know that high vagal tone is a good driver of atrial fibrillation. You can't make a rabbit fibrillate unless you give them acetylcholine. So those are all the big drivers. You add that with advancing age and the standard typical risk factors for atrial fibrillation. You throw in alcohol, which despite my love of red wine is a risk factor for some people. And these things co-conspire to get atrial fibrillation. It can be really tricky to manage, but I think it just falls into the general category of just any repetitive behavior. I've had patients run their way into a pacemaker. People that get second and third degree AV block from running so much, and they say, oh, I was out running my race and my heart rate was going up 100, 110, 120, and then 65. And they go 2 to 1, and they're really troublesome to program that pacemaker to let them do what they want. But I think in most cases, it's this is just regular atrial fibrillation in people that exercise a little bit. I'd say that's probably 2/3 of the patients I see. This phenotype, these middle-aged athletes. There are some who are just hardcore trainers. My partner Stu Connolly, who is now the #2 ranked 70.3 half Ironman runner in the world. And he's, running pretty high. And our other friend, Rich Whitlock of the Leo study, is clocking his marathon under 3 hours now. So, that's a lot of running, but I think it's a mixed bag. But I'm not sure what the correct term is, but, I would have said the aging athlete, but the mature athlete is its own kind of AFib kind of category. Marty, you must see a lot of these individuals. What?
Yeah, but we see it. I'm not sure I know how to treat it. And deconditioning is not an option.
Yeah, no, and again, you decondition, and then, okay, now you're 30 pounds overweight, and guess what? You still have AFib. So, yeah, I always joke. I said I have an easier time getting patients off of crack cocaine than running. Because there's a perceived halo of healthiness around it, right? And what could possibly be wrong with it? And but Paul Dorian has the greatest saying about running, and this is also true. The global benefits are good. And Paul, who's quite the aerobic athlete himself, good friend of Marty's, says, the good news is if you run every day, on average, you're going to live 2.5 years longer. Great. So the bad news is you're going to spend all that time running.
Feel much better.
Well, I think Dr. Healey is also going to meet all of the trainees and residents, so it'll be an opportunity for you to talk to them. And thanks, Jeff. It's always a pleasure to listen to.